I know part of that clap is because we managed to shift the session and allowed you to see the All Blacks, which I actually got the benefit of as I was coming down on the train. I just thought it was an amazing parade. So that's really great. I also would like to thank the organising committee for including a sleep disorder, obstructive sleep apnea, in the program and also in the National Respiratory Strategy. Part of my job is to try and convince you that this is an important condition that's relevant to your day-to-day practice, and that those of you that are working primarily in a respiratory role should also be thinking about your role in the management of this condition, because it's so common that a lot of your patients are going to have this as a comorbid condition with their airways disease. The other goal is, as I've set up in the first slide, is to bring the moe into our title. So, Tiha Ora Moe is the breath of life sleeping. And, you know, I think there's a lovely natural synergy there in terms of how we think of conditions that affect the waking state and conditions that also affect the sleeping state. And it's part of a kind of acknowledgement or recognition that sleep health is actually a really important part of overall well-being. How many of you think you could fulfill that first line? Sleep that is fully restorative, enabling your full potential. Thank you. Thank you. And I think the other aspect of sleep health that's very important is achieving an optimum total sleep time. And one of the things that I was very moved by when one of our first presenters talked about her experience looking after her family with severe asthma is the impact that it had on her sleep. I think she described herself as like a ninja warrior. And so for many people, that experience, that sense that you're in a kind of daydream almost, where you're halfway between wake and sleep, is part of the issues for a lot of sleep quality. These are some of the issues that we confront in a clinical context. So sleep deprivation and shift work are major factors in terms of sleep health. I think nearly a third of the population are shift workers. And sleep deprivation, which is less than 5 hours sleep a night, is a major cause of road traffic accidents and industrial accidents. And we're seeing this across a number of different workforces in this country. The condition I'm going to talk about today is sleep apnea or sleep apnea syndrome, and it's one of the common sleep disorders that we encounter in clinical practice. My interests are, I run the 5th year medicine program in internal medicine and subspecialties, so I have a teaching role. I also run a sleep laboratory and research group. I work as a respiratory and sleep physician at Wellington Hospital. Because I've become more interested in this area to try and change things, I've been made the local president of the Sleep Association of New Zealand, which is a branch of the Australasian Sleep Association. And the aim of that group is to raise the profile of these conditions nationally. And Rob and Api are not here, but we're all classmates of 1985, so we have a nice connection as well, but they both gave me their apologies beforehand. They had to get to the parade, I think. So the overview for the talk is just to describe sleep disordered breathing, to look at some of the prevalence data that we've got in New Zealand. We actually have great science already. We know a lot about this condition and how common it is and the impact it has within a societal setting. I want to talk briefly about health pathways and also about some of the things that we can do as a group to try and raise the priority and create some real change in the area of trying to shift some resources into diagnosing and treating these conditions. And it's interesting, why is it such a silent issue? I think You know, my patients will tell you that snoring is not sexy, but it creates havoc, you know, within the bedroom environment for a lot of patients and their partners. And if you can diagnose and treat this condition, you will have forever grateful patients. You know, we regularly get hugs in our clinics, you know, mainly from the partners when they come back with successful therapy. So it's a therapy that's effective and can really create good health for people. And it's important also that we do this in a partnership, because the problem is so endemic, as I'll tell you, that we're going to have to work together across a whole lot of different areas of health, across pediatrics, adolescents, and across adults, to try and create some real change in how our services are configured. As a group, you all know that obesity is bad news for breathing. So it has some very predictable effects on lung size, oxygen levels, and metabolic demand. But perhaps less well known is that it narrows the upper airway and makes it more collapsible during sleep. So sleep apnea isn't something that happens in the daytime. It is a disorder that occurs when the relaxation of the muscles lead to this collapsing process here at the back of the nose and before the trachea. It's one of three, I guess, common sleep breathing disorders. There's a central sleep apnea as well, and there's also this condition called obesity hyperventilation. Now, most of you will have encountered patients where their obesity reaches a level that the obesity itself pushes them into respiratory failure. And this is most common at night. So when people go to sleep at night, one of the risks of sleep is that your sensitivity to carbon dioxide and CO2 is diminished. So we see respiratory failure early, well before it starts to manifest during the daytime. And we particularly see it in conditions that also overlap with COPD. So you'll see early respiratory failure when you've got this mixture of obesity, obstructive sleep apnea, and COPD. That's a very common presentation within the respiratory community that we see in hospital. How many of you ask about snoring when you are screening a patient in your clinics for respiratory diseases? I've got Jill, I'm glad you put your hand up. Okay, so asking about snoring, I teach the medical students that you've got to ask about snoring and sleep apnea, and I examine them, and they don't. There's something about inquiring about how people sleep that actually people are a little bit nervous about that. You know, you've got to ask about snoring if you're going to diagnose this condition, and you've got to ask about breathing pauses. Now, snoring itself doesn't have to be a problem. So we see down this end of the spectrum simple snoring that can be just a quiet purr that you know the person's there, they've got home, you can relax, and you know, it isn't a health problem, it isn't a health issue. But as snoring becomes more severe, and especially if it can be heard in other parts of the house, then that starts to be the sort of snoring that you see in sleep apnea. So it's one of the important symptoms of sleep apnea, but it doesn't occur in everybody. And we won't dwell on this, but just to make the point that the area of collapse is this area between the nasopharynx and the windpipe, and it occurs as a direct result of relaxation of these muscles that would normally be keeping the airway open, and you get intermittent blockage to the throat, often dips in oxygen saturation, and it happens repeatedly overnight. So in a typical sufferer, they might have obstructions several hundred times per night. And as a result, they often feel shattered in the morning, they don't feel refreshed, and they can feel fatigued and tired across the daytime. This is to sort of talk about who gets sleep apnea, and also because we've got a parade outside. I used to say that the front row of any rugby team were most at risk from getting obstructive sleep apnea, and it used to be true, but not with our All Blacks anymore. You know, our front rowers are like wingers, and you see how Dane Cole play. You know, they're so fit that they're not necessarily carry those same risk factors that they used to before. Studies that have been done in the American Football League show that about 50% of the defensive line have moderate to severe obstructive sleep apnea. So it's very common in elite sportsmen where bulking up, and especially bulking up around the neck, is part of what they do for training and for the type of fitness that they have. Oh, sorry, there was another point. The other point is that sleep apnea can affect children. So we don't think of it just as an adult condition, it's an important pediatric condition. And so recognising that tonsil hypertrophy in kids is probably the leading cause is very important, and that these children often present with failure to thrive. So they're not actually presenting in the same way as the adults do. They can present with failure to thrive, issues with hyperactivity, inattention, some of the common symptoms of pediatric sleep apnea. And if you look, this is what you might see in a child with pediatric sleep apnea. So these big kissing tonsils that we see here predispose the upper airway to obstruction. And it's very obvious when you can sort of see it there. You know, the muscles there are working incredibly hard to keep the airway open, awake. Just takes the slightest bit of relaxation, and there you get intermittent obstruction while they're sleeping. The other features that we look at clinically are listed here, so things like an enlarged neck, a small oropharynx, shortness of the jaw, and this is these dental occlusions that I've shown here. So the patient at most risk is this one in the middle, where there's an underbite, so we call it a class 2 occlusion. You see this often in sleep apnea sufferers who have normal body weight. So this is the group who aren't necessarily overweight in terms of getting OSA. This is what's called a Mallampati score, which is used by anaesthetists to classify who's at highest risk of an intubation. So they use this score to decide who's difficult to intubate, and the ones predictably are the 3s and 4s, and they're also the ones who tend to get obstructive sleep apnea. Why is it important? Well, in its full-blown form, it leads to this reduction in quality of life as a result of tiredness and fatigue, reduced energy levels, concentration span. People just feel sort of old, well before their time. And if this is happening at a part of your life when you're at your most productive, it's a real impediment because you just can't, you don't have the energy to do what you'd normally be into. And it also manifests itself as an increased risk of traffic accidents. So we see a 2 to 3-fold increase of car crashes and also industrial accidents in the workplace. There isn't very good data on mortality. You'd think with something that was happening every night that this would be highly likely that people would lead to their death on the night that it happened. But you have an arousal system that's built to relieve the obstruction, like an alarm system that kicks in at the end of an apnea to open the airway up, so that it's a cycle rather than those apneas continuing. But the one exception to that is when people drink a lot of booze or have a whole lot of drugs on board or are recovering from an anaesthetic, when you can get blunting of that arousal response and it be more risky. There are pretty good links now that have been established with the development of hypertension, so a 2-fold risk of developing hypertension. It's a risk factor for incident coronary artery disease and congestive heart failure, and is being subject to a large trial. There's a large trial at the moment looking at people who have ischemic heart disease where the CPAP therapy can alter their secondary outcomes from that. Diabetes is also thought to be a consequence in some patients who have obstructive sleep apnea. And as I mentioned before, if you have this condition, it tends to promote early respiratory failure if you've got an underlying other respiratory disorder or heart failure. These are some of the treatment options. So nasal CPAP is the one that you'll be most familiar with, but it's not the only therapy. There are other modes of PAP therapy that have been developed. Weight loss is important via dietary or bariatric means. Sleeping on your side, the use of oral appliances, in some cases upper airway surgery, particularly when the tonsils are enlarged, and also in selected patients moving some of the bones of the lower jaw. Just again, these are just to show you some of the dental appliances that have been used to manage sleep apnea. So probably around maybe 20% of our patients might be treated with an oral appliance. So again, they're usually people who have an underlying predisposition in their upper airway. They're normally not the most overweight patients, but they are quite effective when they hold the lower jaw forward and make a bit more space in behind the tongue. This device here is an interesting idea that's been developed particularly in children who have a very narrow maxilla, and it's aiming to expand the maxilla and open up and make more room for the tongue so that the tongue sits forward in the upper airway. And that's actually been shown to be a very effective in pediatric sleep apnea. CPAP is shown here. It's successful in moderate to severe obstructive sleep apnea, but it needs to be introduced as part of a treatment plan and program. So CPAP works very well if you've got a dedicated and committed team who know about the treatment, know about the side effects, know how to adjust it, and know how to encourage the patient. And that's particularly important in the first week or two of therapy. It prevents upper airway obstruction during sleep, improves symptoms, quality of life, lowers blood pressure, although not as much as we'd originally thought in the early studies. But if you're hypertensive, it probably reduces your blood pressure by around about 10 millimeters of mercury, so that's not bad. And if you've got diabetes, it improves glucose tolerance, but only if you can use the CPAP for around 7 to 8 hours a night. Studies where they've used it less than that tend to show not much effect on diabetes measures. And from a public health perspective, important improvements in crash risks and accidents. I thought this was a good kind of take-home statement about the effects of sleep apnea in terms of crash prevention. So this is from a meta-analysis of a whole lot of studies in a whole lot of countries, and it shows that you need to treat 5 patients with obstructive sleep apnea to avoid 1 crash. 5, okay? You need to treat 3 to avoid a near-miss episode. So, this is highly effective intervention if you can target it to the right population. Now, these are patients who are presenting into clinics, so they've already got symptoms, and some of them have presented because they have had a crash, so it's part of why they're attending. But, these are extraordinarily low numbers needed to treat for a successful clinical outcome. This has been looked at recently in Sweden, and I'm just picking this study up partly because I thought it was very well done and lovely systematic look at the issue of crashes in OSA patients. And the reason I thought it was important is not that it showed that CPAP lowered crash risk, because we knew that was already the case, but because it identified some of the other really important risk factors when you're dealing with a person who might have had a crash. And so I've shown those there. And in this study, they found that those factors were also very important in terms of why people were crashing. Things like having less than 5 hours sleep a night, those that continue to drive whilst feeling sleepy, those who were driving longer distances, and those who were using hypnotic medication. So how common is this condition? So I'm going to talk now about a New Zealand study, a prevalence study, and also bring in 2 other international studies that have looked recently at sleep apnea prevalence. So the most important, and it's really the only New Zealand prevalence study, was done in collaboration between our research group and the Sleep Weight Research Centre at Massey. It was undertaken by Kara Mahiri, and it was done using what would be called, I think, a kaupapa Māori kind of protocol, and the study was enriched to try to see whether there were higher prevalences in our Māori population in comparison to the non-Māori population, because it was suspected clinically that this actually was the case, and we know that the risk factors that were there could be important, so that's why it was designed that way. This kind of study is a little bit busy, but the aim of it is to show you these are sleep apnea symptoms like snoring always, observed apneas and feeling sleepy. This is called the Epworth Sleepiness Score. And it's showing them in comparison to the level of socioeconomic deprivation, so what's called the NZ DEP score, which is a metric that goes from 0 to 10, where the level of socioeconomic deprivation can be compared across different zones within the country. And those zones are shown as the reddest areas are the highest levels of socioeconomic deprivation. And they coincide, particularly with areas where you're going to see higher levels of sleep apnea symptoms. So the idea of the slide is to think of these are actually the at-risk areas, because these are where we're seeing more symptoms of this condition. And it tends to coincide with higher body mass index in those zones as well. In Kara's study, what she found was that the prevalence of obstructive sleep apnea was pretty similar overall to international studies, but was higher by about 2 to 3-fold in Māori compared to the non-Māori group. So this is an indice called the apnea-hypopnea index that we're measuring here. Don't worry too much about the absolute values, but the difference here was about 2 to 3-fold between Māori and non-Māori, and it was seen in men and women. This is just another way of showing the same information here. I would emphasise at this point, although it wasn't measured as part of this prevalence study, that Pacific Island is also likely to share a much higher prevalence for this condition. And we saw from Api's slides yesterday, that in some Pacific Island groups, the level of obesity is just getting higher and higher to the point that it must be a very big risk factor for this condition. How does this compare internationally? Well, this is a study called the HypnoLaus study, which is designed to look at prevalence amongst Swiss. And the difference between our study earlier on and this study is they've started using different ways of measuring sleep apnea. So they're measuring like more sensitive tools that measure airflow rather than dips in oxygen levels and snoring intensity. And what this study showed is that the initial sort of teaching about the prevalence of this condition is going to have to be adjusted. So in Switzerland, like in other countries, they're seeing rising levels of obesity, and the prevalence has gone up by about 2-fold in comparison to what they thought they were going to get. So the measures that I've shown you are almost certainly on the rise in this country as well. What about impact? Well, we've been lucky enough with Philippa Gander's group and the Guy and Helen Scott to have some studies that have looked at the societal costs in New Zealand of obstructive sleep apnea. And they used a thing called Monte Carlo simulations. It's a lovely kind of sounding piece of statistics. I have no idea what it is. But, the idea of it was you can assign costs to certain aspects of a particular condition and also look at what the treatment-related effects would be and compare the costs that you could save if you identified this condition and actually started treating it. And the main risk factors that they were looking at that drove those costs were motor vehicle accidents, other accidents, a rise in diabetes, and a rise in cardiovascular disease. And the details of this aren't important, but they included direct and non-direct and indirect costs, and they were conservative. Okay, they took the view that they were only going to quote things where they thought there was pretty solid evidence for it, possibly too conservative. We'll get to that in a minute. But anyway, that was the lowest range of the total costs that they came up with, of $40 million. The upper range was about $90 million for the cost of this condition per annum. The other interesting thing about this study that we helped with in our group is that we gave costs that would be required to actually diagnose and treat the condition. So it's based on a range of treatment costs, including seeing your GP, seeing a specialist if that was necessary, the provision of CPAP therapy or a dental splint, surgery in some cases. And what they determined was that the treatment cost or cost effectiveness per quality of life gained was about $94 per quality, which is extraordinary when you compare it to other things that we invest in. the upper end of that cost range is about $300 per QALY, and that compares to about $7,000 per QALY, which is what Pharmac consider a reasonable thing to buy a drug for, to invest in terms of what we spend our pharmaceutical budget on. So this is highly cost-effective treatment if you're looking at these types of analyses. So what can we do about this tsunami of sleep apnea? You know, what are the things that might change the prevalence? What are the things that we can work on as a health system? They're the hard ones just listed to begin with. You know, I think weight loss would make a big difference to the drivers of OSA prevalence, but no one's yet figured out how to actually do this. You know, we've got debates going on about sugar or carbohydrate or fat. You know, there are obviously things in our diet at the moment that are not being helpful. I think the shift to a carbohydrate diet is driving a lot of obesity at the moment, but according to my cardiologist, we're seeing less ischemic heart disease, so I can't really quite figure that. But it's certainly that the changes at the moment are driving OSA prevalence. Smoking seems to affect the upper airway as well, so you get inflammation, narrower airway. It seems to be a risk factor for OSA via that mechanism. And of course, alcohol and other sedating drugs. I liked this slide. So this is a picture of the largest man in the world in 1903, an American police officer in 2012. So our view of weight has changed. You know, we are kind of accepting that we all are going to be carrying a bit more, and the stats kind of back that up. This is the proportion of obese Kiwis, and it's on the rise for the adult age group. And we know from pretty good prevalence data that as that goes on the rise, we'll see, if we get a 10% increase, we'll see about a 30% rise in OSA prevalence. Big changes. What else can you, nevertheless, a public health response will be essential to this. So we can't solve all the OSA issues without some sort of meaningful public health response in that area. There have been various diets that have been tried, and they're pretty effective early on, but people don't seem to find it at all easy to stick to a dietary change. So you get some weight loss and then it returns. What about CPAP therapy in New Zealand? Well, it's pretty effective if you set it up in the right location. One of the good things is it's funded by New Zealand DHB, so if you're diagnosed with obstructive sleep apnea, there's an obligation within our system that you be provided with treatment. How it is initiated matters, and you see a huge range of reported outcomes when people do it a bit differently. And the latest that I saw was a study called the PREDICT study, where they looked at older people on CPAP in Europe, and they just gave them a machine and said, take this away, and it was going to automatically adjust things for them. And then they reviewed them 2 months later and sort of decided that they'd follow up at that sort of 2 monthly intervals. And the use of CPAP was appalling, and they were only about 20 or 30% were using it successfully. And they published this and said, you know, CPAP works in the older population, but the actual average use rates were far lower than we would accept in our clinical context. So you should be able to achieve about a 70% success rate if you've got a program working well. We've also been interested in patient-related factors in terms of the success of CPAP, and have been focused as well on one of the concerns that was raised early on when we were looking at some of the differences in the severity of sleep apnea, is that Māori might be presenting later and with more severe disease than other New Zealanders. We as a group, so we've known that this is the case, so as a group we've been interested to look at whether your ethnic background, whether these ethnicity that you're from can predict your outcomes in terms of CPAP treatment. And what we found in our program was that the average use was a little bit lower in Māori versus non-Māori, but a lot higher than what you see in other programs and other quoted areas. So we saw a difference there in terms of average compliance. But when we burrowed into that and looked at what the drivers for that were, what we actually found was that the level of socioeconomic advantage actually had something to do with what was actually going on. So people who were in the most disadvantaged quintile here had the lowest CPAP use, and that was actually the main driver of the effect that we measured, rather than ethnicity per se. We've also done some focus groups looking at barriers to care across different populations, and in this focus group found that that a lack of knowledge about OSA and CPAP treatment was one of the main barriers. So people just were in denial a bit about the process of accessing treatment, that there were financial barriers to accessing therapy, either to see their GP or to get to some aspects of the treatment pathway, and that in some areas they were overwhelmed with the amount of information, so that maybe the information wasn't being given in a way that was ideal for those different groups. So now I'm going to look at how OSA is sort of managed and diagnosed in this country. And those of you that are involved in any aspect of these services in New Zealand will know that it's quite variable. So there are some areas where it's managed well, and there are some areas where there are no services at all. And obviously, that's sort of the worst outcome that we could see in a condition as common as this. But equally, the way the system is funded, we've had a Ministry of Health that's provided some funding and no control to anybody. So there's no regulation. So that there's been this sort of organic process of trying to develop services where people who've been keen have just sort of got on and tried to diagnose and develop the services there with some support from professional groups. So we've got lots of different models of care. Generally speaking, in New Zealand and in the UK, we are strongly accepting of portable testing for the diagnosis of this condition. So you can test in the home environment to make a diagnosis of obstructive sleep apnea. The opposite has been true in the US and to some extent in Australia. But what you can see is that the latest guidelines are now leaning more and more towards the use of portable testing to try and help manage the burden of disease in obstructive sleep apnea. And this is, I spent a night once upon a time drawing little pretty pictures for you, but this is just to show you the types of tests that are done in different parts of New Zealand. It's only 2010, so it's not particularly up to date, but it's the idea to show you is that there's quite a lot of variation. You know, people are using different testing regimens, but over time what we're seeing is a greater use in 2010 of these unattended studies, level 3 and oximetry. So this is cardiorespiratory and oximetry. We surveyed this with the help of Sarah Jane Payne in 2010, so it's a little bit out of date, but we wanted to get a stock take of what the services were actually like, how interested DHB's services were in the condition and what sort of services they were providing. We had a pretty good response rate. 18 of 18 DHBs who we sent the questionnaire to responded, but only 3 of 18 listed sleep disorders, and this is mainly obstructive sleep apnea, as a priority. So they didn't see it as a priority in hardly any of the DHBs. And only 2 of those DHBs had any form of accreditation, so not much in the way of standards, unfortunately. There were a variety of tests that were being done, which is shown on this slide, and quite a lot of wait time. You know, there were in all aspects of the system, so lots of people waiting a long time to try and get access to diagnostic testing and services, independently of the type of testing being done. Although I think, as a general rule, the home testing can usually be accessed more quickly. We tried to find out how much money was being invested in the OSA pathways, and it was quite difficult. And I've listed there, we got information on 10 out of 18 and found that there was quite a variable amount of money being spent, but overall not very much. You know, if you look at the amount that could be achieved versus the amount that's being invested, it's not very much. And also, disappointingly at that time, these services were not being utilised to capacity. So even though we've got this high prevalence process, the services were being constrained in their funding model and in the the amount of investment that was going in there. And they were also not diagnosing other sleep disorders. So about half of them were able to diagnose some of the alternative sleep disorders that can, manifest itself as the sleepiness of OSA, but actually turn out to be a different condition. This is a recent article that has been developed by the Australasian Sleep Association, which aims to provide guidelines, if you like, a pathway by which testing can be chosen. And one of the very good things is that it includes portable studies. So level 3 and level 4 studies are now being endorsed in the use of in settings of high pretest probability, which should allow this to be rolled out to areas of higher prevalence. So just in the final few minutes, what else can we do? Are there any other things that we can't? Well, there's lots of things that can be done. My main message is that we need to invest more in this. One of the things that's been frustrating is that despite calling for that, it's very hard to actually affect that type of change. This was a comment made by the Australasian president about the issue that they're having with diagnosing this condition. He said there won't be one solution. You've got to look at multiple solutions across a whole lot of different types of pathways that would include primary care, include integration with secondary care. Maybe different for urban versus remote. And that the future will see a growth in these portable types of sleep testing, which hopefully will start to meet some of the higher prevalence. We need to see some integration of services, particularly in terms of the way I work with sleep testing centres, providing a range of different test strategies depending on the particular clinical question. And we need to improve access to diagnosis and treatment for Maori and Pacific Islanders, because they are carrying a high burden of disease in this setting, and they also deserve the best access that we can create for this sort of testing and treatment. To do this, we need to expand our clinical workforce, and this is partly why I'm talking to you passionately today, is, you are seeing these patients, you're possibly overlooking some of their sleep apnea issues, you may be working in environments where perhaps your testing isn't being invested in. I don't know, I'm possibly speculating there, but I can't think of a single DHB where they would be saying, yes, we're fully resourced and we've got enough to actually provide the treatment that we need. That doesn't exist at the moment. We need to we need to train sleep physicians, which I'm interested in doing, and sit on a committee for this. But also we need, our respiratory colleagues to be getting involved in this in terms of respiratory physicians, potentially internal medicine physicians, GPs who are interested in managing sleep disorders. We need to look at nurse-led clinics, and we need to interface effectively with primary care. So these are some of the other issues that perhaps we could talk about or raise. I think that the National Respiratory Strategy should be congratulated for including obstructive sleep apnea as one of its focuses, because it is a highly prevalent condition that's otherwise being overlooked. But it has to be as a partnership with other groups actually pushing some of these issues. And I know the New Zealand branch of the ASA are very interested in promoting these issues. We need to look at workforce development and partnerships with key organisations. And overall, in my view, just start to rank up the investment in this area right across the board, because we have the research, we have the societal costs, we know it's a big burden of disease condition, but we don't have the services that are there to actually meet that. Thank you.
Thank you very much. We've got time for a few questions, if there are any.
That was really rung true for myself and clients I see. What I also would like to add as a nurse, when you see your clients, you ask them, and you may see them, they're feeling quite sleepy on it, and you ask them, do they wake up at night and go to the toilet? They pass urine. Do they wake up a few times at night? Do they wake up with a heavy head, or I can't think? Can I remember where I left my keys? You go to work, you function, and this is the early stages of obstructive sleep apnea, and this can go on for many years, and you may be very healthy, but they are early signs. Now, I have a history where my mum and my nan both died in the early 60s. They had dementia, Alzheimer's, CVA and strokes. They were tinier than me, but they snored. And I remember Dad sleeping in the other room. And of course, when I was married, that's exactly what happened to me for many, many years. I came here about 8 years ago, my first conference, and Ruth Gardner did the talk on obstructive sleep apnea, and I ticked all the boxes. I went to my GP and I said, I have obstructive sleep apnea. She says, oh no, you possibly can't have that. You've got a little bit of blood pressure, you're not on any pills. I said, I want a test. Now, I had bought the dummy devices, I'd have my soft palate microwaved, my partner paid for it because it was very difficult on our relationship. I did all that. I was very fortunate because I was my own advocate and I didn't want to die at that age and lose my mind. And so I had the sleep studies. I was blessed, and I was in a situation that I actually had sleep apnea and I got a free machine through the hospital. But there are so many other clients that cannot afford that. And so with all this, we do need to look at that because it's such a big picture and it starts at an early stage. So ask those clients those questions. And you might think, oh, it's not bad. Don't wait till it's bad. Make sure it's at the beginning and make a note in your history. Do the sleep scale and what's happened and be an advocate for those clients. So kia ora for that. And I'm just so lucky because I know if I didn't have my CPAP machine, I would not be here. I wouldn't have my brain. I would be exactly like my nan. And I wonder whether it's also hereditary. I have 2 girls that have been privately tested for sleep apnea. They both have machines. I can see a genetic link with my aunties, and I can also see it with my grandchildren. They've had tonsils and adenoids out, so by crikey, I'm aware of all this, and I don't want to go down that stage. So please
Thanks,
be.
Tui.
Thank you,
very
Tui.
much. Kia ora.
Got one here.
Just to quickly address one aspect that you asked about too, there is clearly some genetic components to this, and also the shape of the airway is important. It's not just weight. There are collapsing factors that are variable between people, and the way the breathing pattern waxes and wanes also a trait that looks to vary as well, and that's probably genetically determined.
Because one box doesn't fit all.
That's right.
Thank you.
You don't have to be big to have obstructive.
Thanks, Tui. Yeah, we just got time for a couple more
Kia ora.
short ones.
Just one comment. The diagnosis and treatment and taking things out into the community is fantastic. The one bit that's missing is the follow-up, the checking in with people to make sure they are using their CPAP machine, not just that they have one. And we have particularly found that in Canterbury and amongst our Māori and Pacific Island people, they've often got a CPAP machine, but they're not using it. And it might be something as simple as getting a decent mask fitting. So that's the other part of the puzzle, just to make sure that that's happening too.
Thank you. Most of the secondary services that are starting CPAP are discharging patients into the community now for follow-up. So, yet we don't have a good chronic disease model of funding for this condition either. So follow-up's really important, and I'd endorse what you're saying.
Last brief question.
If you can deal with the sleep apnea, you're lowering blood pressure. That's one of the things. What's the physiology behind that, the actual physiology, and also you're having effect on the diabetic patient as well with fixing their sleep issue. So what's the physiology behind that?
Okay, so the the hypertension question is that with obstructive sleep apnea, you are a non-dipper, which means that normally blood pressure drops overnight, but with obstructive sleep apnea, it repetitively goes up and down. So you see surges in blood pressure throughout the night. And we think that resets your carotid sort of chemoreceptors to a higher pressure overall. So it's a sympathetic drive is one of the key predictors of that. The second question was about diabetic. So that's probably been the most controversial aspect of OSA management, and there are mixed studies. So the ones where CPAP is being used for lower amounts of time, probably not much of a signal, but a very good study this year showing that if you can use it for the whole night, that some of the indices of diabetes change. I think by the time someone's a type 2 diabetic, a whole lot of other changes have occurred that make them insulin resistant. And also, with effective CPAP therapy, weight doesn't necessarily get dropped off. So because you're reducing metabolic energy expenditure overnight, you have to diet and exercise to lose weight. Otherwise, weight will increase slightly on CPAP therapy.
Thank you, Alister. I'll ask Matthew to.
Alister, it's my pleasure to be able to pass this vote of thanks, I guess, for such an interesting, comprehensive presentation. It's very interesting that we've had presentations very much focusing on action, presenting the issues, but also presenting the actions, which you've done very ably, and I thank you for that. I guess my other observation would be that in many of our presentations, we are seeing the same conclusions around access to diagnosis, service provision, equity of access, and again, we hear that too. So thank you very much for your presentation, and I think everyone has taken a lot from it, so thank you very much.